Immune disorders. Allergic disorders are characterized by a hyperimmune response to weak antigens that are usually harmless. Antigens will cause an allergic response, or antigens that do cause an allergic response are called allergens, and they gain entry from the environment. An allergic reaction may be sudden or gradual, and it may gradually disappear and or be replaced by a similar sensitivity to another substance. It's characterized by the manner in which the allergen gains entry to the body and the intensity of the response. Allergies can occur at any age. Affected organs usually involve the skin, respiratory system, GI tract, blood, and vascular system. Allergen types include ingestants, which would be food or drugs, inhalants, which include like house dust, mites, contactants, which would be like latex, or injectants, which would be drugs or bee venom. Allergy examples include allergic rhinitis, contact dermatitis, food allergies, urticaria, and angioedema. The first exposure to an allergen does not produce symptoms, but it does cause the body to begin to be sensitized to that allergen. The sensitization is a process which cellular and chemical events occur after a second or subsequent exposure to that allergen. Once sensitization occurs, one of four types of hypersensitivity responses can occur, and these responses can be immediate or delayed. So we have type 1, 2, 3, and 4. The immediate hypersensitivity response is due to antibodies interacting with allergens, and it does occur rapidly. Type 1 is the most severe. We have atopic or anaphylactic, and it's mediated by immunoglobulin E antibodies. It is the most severe. Type 2 is cytotoxic. It's mediated by immunoglobulin M or G antibodies. Type 3 is an immune complex mediated by the IgG antibodies. Type 1 and 2 can occur within minutes. Type 3 responses will reach a peak within about 6 hours after exposure to an allergen. Anaphylaxis is a rapid and profound type 1 hypersensitivity response. We see a massive release of histamine, which causes vasodilation and increases capillary permeability. These clients may have an angioneurotic edema, which would be acute swelling of the face, neck, lips, larynx, hands, feet, genitals, internal organs. We see hypotension and bronchoconstriction. This can be fatal if it's not treated quickly. Delayed hypersensitivity response, which is type 4, the antigens are initially phagocytized by macrophages. The sensitized T cells will then produce cytokines that cause an inflammatory reaction, and it can develop over several hours or days. So there's mechanisms to the suppression of the allergic response, and this includes release of eosinophil chemotactic factor or ECF. This is a chemical mediator from mast cells, and it suppresses inflammation. Chemotaxis is the process of attracting migratory cells to a particular area of the body. Epinephrine interferes with the release of vasoactive chemicals from the mast cells. And corticosteroids, these anti-inflammatory hormones that will block the synthesis of prostaglandins and leukotrienes. So these clients may experience shock, laryngeal edema, wheezing, stridor, tachycardia, generalized itching, again hypotension, bronchospasm, and the angioneurotic edema. With a less severe localized hypersensitivity, we may just see watery eyes, increased nasal and bronchial secretions, sneezing, vomiting, diarrhea, hives, which is that urticaria, itching, localized redness, and dark areas under the eyes. Excuse me. With ingested food allergens, we may see cramping, vomiting, and diarrhea. And with the injectants, that venom, it produces a systemic, potentially fatal effect, shock, and airway obstruction. We diagnose with radioallergosorbent blood test, or RAST. We can do the skin test, which would include a scratch or prick test, a patch test, or intradermal injections. And what we do is we just basically apply or inject extracts of various substances or different antigens to try and see if the client is reactive to those particular substances. And we can also do elimination diets where we try and establish cause and effect relationships. If you eat or drink certain things, you try to eliminate certain things that could cause allergic reactions and see if symptoms improve. Complications. Clients that have inhalant allergies or allergic rhinitis can develop nasal polyps from chronic inflammation. They're also prone to sinus infections, secondary pulmonary infections, and asthma. Treatment will be used to relieve those allergic symptoms, and that will be dependent on the type of allergy. So we can use drug therapy such as antihistamines, which are indicated for nasal allergies, urticaria, common cold, allergic reactions, and motion sickness. Contraindicated though with narrow angle glaucoma, cardiac disease, hypertension, kidney disease, bronchial asthma, COPD, peptic ulcers, seizure disorders, and BPH. It does cause a sedation. We may also see anticholinergic effects such as a dried mouth, blurred vision, decreased urine output, and constipation, because antihistamines will dry you out. It can enhance or decrease some drug effects, so make sure that you're looking for potential interactions before administering. A couple of these antihistamines may include loratadine or diphenhydramine. We can also treat by desensitizing a client. This is an treatment where the person will receive weekly or twice weekly injections of a dilute but increasingly higher concentrations of an allergen without interruption, and this helps desensitize the client to the things that cause those hypersensitivity reactions. And we can also do the sublingual swallow immunotherapy. Make sure that if a client is having edema, that we remove any constrictive items such as rings. Schedule for diagnostic skin testing, encouraging the client to avoid taking prescribed or over-the-counter antihistamines or cold preparations for at least 48 to 72 hours prior to the test. Some of these clients may be prescribed EpiPens, and they need to be instructed on how to use them. We may also be administering serial doses and monitoring after desensitization, and doing client and family teaching to help avoid or restrict exposure to any of these potential allergens. A mnemonic for anaphylactic reactions. As the nurse assessing the client, which of the following is a symptom that the client with anaphylaxis may be experiencing? These clients may experience wheezing due to that bronchoconstriction. A nurse would evaluate that the client understands what triggers allergic rhinitis by which of the following client responses? This is going to be your airborne pollens and molds. Remember, rhinitis, it's going to involve the nose, so anything that would be inhaled. Autoimmune disorders involve killer T cells and autoantibodies that attack or destroy natural cells that are considered to be native to that person or self. Autoantibodies are antibodies against self-antigens, and these include immunoglobulins. They target histocompatible cells that the antigens match the individual's own genetic code. Diseases that are considered to be autoimmune are considered that when they're characterized by unrelenting progressive tissue damage without any verifiable etiology, such as hemolytic anemia, multiple sclerosis, myasthenia gravis, ulcerative colitis. And these diseases, some of them may be discussed in different areas. Alloimmunity describes an immune response against transplanted organs or tissues that carry non-self antigens. So autoimmune disorders, there's several theories that have to do with the cause, and a couple of them include the tissue injury theory, which involves infection, trauma, or introduction of a drug that integrates itself into the membranes of the host cells, such as streptococcal infections and rheumatic heart disease. Another theory is genetic instruction theory, which we have genetically predisposed cells to autoimmune disorders. Or sequestered antigen theory is another theory. These clients with autoimmune disorders have symptoms that depend on the tissues and organs that are affected. These symptoms are characteristic of an acute inflammatory response. They may experience a low-grade fever, malaise, fatigue, and weight loss. Inflammatory symptoms may develop as antibodies attack normal tissue that's mistakenly identified as non-self. In other words, with autoimmune, the client's normal defenses are attacking itself. It is destroying its own tissues because it recognizes them as being non-self. Exacerbations will alternate with periods of remission in these clients, and the duration of these periods can be completely unpredictable. We diagnosed with erythrocyte sedimentation rate, or the ESR, anti-streptolysin O titer, anti-nuclear antibody titer, and rheumatoid factors. These disorders are rarely going to be cured, but we will treat with anti-inflammatory agents, immunosuppressive agents, cytotoxic agents, and corticosteroids. So it's very important for nurses to obtain a good family history, watch those vital signs, examine the client for signs of localized inflammation and compromised body functions, assess the level of energy, and review lab test findings. Make sure that you report patterns to identify any exacerbations. So let's talk about a couple of those autoimmune disorders. And the first one will be rheumatoid arthritis. Rheumatoid arthritis is an autoimmune systemic inflammatory disorder of connective tissue and joints, but primarily synovial tissue. It may also affect other body systems such as the eyes, skin, heart, lungs, kidneys, and blood vessels. It is the most common form of autoimmune arthritis. Risk factors include a genetic predisposition, smoking, and hormonal factors. These clients are going to have an acute onset of symptoms. They will have bilateral symmetrical joint involvement. In other words, you're going to see the same deformities on both sides of the body. So if you look at this picture of the hand in the slide, the other hand would look very, very similar. We may also see some subcutaneous nodules, muscle atrophy, flexion contractures. These classic deformities, again, like in this picture, swelling and warmth. We diagnose through x-rays, serum protein electrophoresis, arthrocenteses, a CRP, and ANA tests. Medical and surgical management. Again, this is an autoimmune disease, so there's no cure. Our goal is going to decrease joint inflammation, and relieve discomfort, prevent deformities, restore function. And we can do this through drug therapies, some non-drug therapies, such as physical therapy and occupational therapy, and surgery, such as arthroplasty or synovectomy. Some immunosuppressants that may be used would be your calcineurin inhibitors. These drug levels have to be monitored because of their narrow therapeutic range. There is a risk for renal impairment, serious and fatal infections, liver injury, seizures, encephalopathy, and skin cancer. Very important that these clients avoid ultraviolet light and sun exposure. 3 of these drugs would be Sandimmune, Neoral, and Gengraph. We may also administer glucocorticoids or the corticosteroids to help treat RA. Contraindications would be cataracts, glaucoma, peptic ulcer disease, mental health disease. Use in caution with diabetes mellitus because they do increase glucose. Adverse effects include that moon face, hyperglycemia, psychoses, adrenal suppression, fluid retention, slowed wound healing, weight gain. It can also thin the skin out. Drugs would include like your prednisone and your methylprednisolone. NSAIDs would be another medication we might use with these clients. We want to avoid giving it if the client has a vitamin K deficiency, peptic ulcer disease, or pregnancy. Adverse effects include heartburn, GI bleeding, renal failure, increased risk of heart attack or stroke. It does interact, salicylates can cause increased transient liver enzymes levels. It can also cause hyperkalemia and hyponatremia. These drugs would include your aspirin, your Toradol, Celebrex, meloxicam, ibuprofen, and naproxen. And then we have our DMARDs, our disease-modifying anti-rheumatic drugs. These are specifically used for rheumatoid arthritis. It is contraindicated in active bacterial infection, active herpes zoster, active or latent TB, hepatitis B or C, contraindicated with some drugs such as etanercept, infliximab and adalimumab because it can increase the risk of heart failure, lymphoma. With methotrexate or leflunomide should be not used with pregnancy or lactation. These drugs, abatacept, will increase the risk of infection, and adverse effects will include headache, upper respiratory infection, hypertension, increased risk of infection. Etanercept is also used for plaque psoriasis, and adverse effects include that headache, upper respiratory infection, dizziness, and weakness. Leflunomide, diarrhea, upper respiratory infection, alopecia, and elevated liver enzymes are common adverse effects. And methotrexate is also an anti-cancer drug and can cause bone marrow suppression. And then lastly, we have our antimetabolites, our folic acid analogs. Adverse effects include hair loss, nausea, vomiting, and myelosuppression. This is going to be your methotrexate. We need to make sure that we're teaching our clients to maintain their health, relieve pain, reduce stress, decrease inflammation, preserve joint mobility, and stick with your medication regimen. And the last autoimmune disease we'll talk about is Myasthenia Gravis. And we've talked about this before. This is a neuromuscular disorder. It's also considered to be an autoimmune disorder, characterized by severe weakness by one or more groups of skeletal muscles. The antibodies will bind to and degrade that acetylcholine receptors on the surface of skeletal muscles, occurring more often in women than in men. So these clients may have ptosis of those eyelids, difficulty chewing or swallowing, diplopia, voice weakness, that mask-like facial expression, weakness of extremities, and the respiratory system. We treat it once again with the administration of the anticholinesterase drugs, prednisone, immunosuppressants, plasmapheresis, or removal of the thymus gland.